there is thromboplastic materials entering into the maternal uh, circulation. It causes consumption coagulopathy, which activates the extrinsic coagulation pathway. So there is reduction in the fibrinogen level. There is hyperfibrinolysis and raised FDP. In this condition, tranexamic acid helps. So we have to order other tests also, like prothrombin time, platelets, fibrinogen level, and fibrin degradation product. These tests should be there if we are suspecting DIC. And as you see in this chart, there is a scoring system. If the score is more than 5, it is the diagnosis of DIC is made and we have to manage it accordingly. If the patient's score is less than 5 and the patient is not improving, deteriorating, the hemodynamic stability is not getting maintained, then we might have to repeat all these tests and reassess. So in cases of DIC, we might have to activate the massive transfusion protocol. There has to be a system in place in the institution. The blood bank should be prepared with the MTP kits. So as soon as the MTP protocol is activated, they will send the first kit, which includes one blood, one PRBC, one FFP, and one platelets. And in certain condition, the 10 units of additional cryoprecipitates or fibrinogen concentrates might also be kept reserved for such patients. As soon as once the MTP1 protocol, one kit has been released, the blood bank should start arranging the MTP2 kit. Once the blood has been transfused, we have to check and keep on monitoring the electrolytes. That is, patient might present with hyperkalemia, hypocalcemia, and hypomagnesemia. So we have to replace magnesium and calcium and potassium if necessary to avoid cardiac arrhythmias. Additional blood products may be required. At every step, if there is an ongoing blood loss, then we have to keep on resuscitating the patient. If the patient starts improving, the MTP protocol is discontinued. The most dreaded complication of abruptio is maternal mortality. Patient may present with hypovolemic shock, renal failure, DIC, PPH, resensitization, and complication of massive transfusion. In negative patient, in abruption, it is important that we should keep in mind that patient might require a higher dose of anti-D, and in such condition, it's important to identify or quantify the sensitization that is happening so that the dose of anti-D can be optimized. The most dreaded complication is fetal demise. It can cause hypoxic injury to the fetus. In cases of chronic abruption, patient might present with IUGR and there can be neonatal anemia. Prevention is less likely, but still we can counsel patient if they are in habit of consumption of tobacco, cocaine, or smoking. We can counsel them regarding avoiding that. If they have history of abruption in previous pregnancy, we can give them the cues when they should be suspicious and they should report to the hospital immediately. If they have developed hypertensive disorders, whether if they are hypertensive from before or they have developed preeclampsia, a better surveillance and better control of hypertension has to be done. So to conclude, abruptio placenta is an important cause of fetal and maternal morbidity and mortality. The etiology is poorly understood. However, the management options are available depending on the stage at which patient presents. The principle of initial assessment of the patient condition and subsequent planned management is aimed at resuscitation and prolongation of pregnancy if possible, or immediate delivery, either for fetal or maternal indication. Thank you.